I am my name is Antony Stately. Bonjour, everyone. I am enrolled citizen of the Oneida Nation of Wisconsin and a descendant of the Great Red Lake and White Earth Nations of Minnesota. And I was born and raised in South Minneapolis, and the place where Native American Community Clinic is situated along the cultural corridor. And yeah, so I was born and raised here, and so for me to be in the role of being the president and the executive officer of NACC, it's a tremendous honor and privilege to me to be able to come home to my home community and serve the relatives who gave birth to me and also raised me into the young well, I'm not a young man anymore. Younger than some people, but not younger than most people on this call, I think probably. So I just wanted to kind of situate there that I'm gonna talk about the work that NACC is doing, a little bit of our history, how we got to where we're at. I'm gonna share, I think, most of the, we're doing quite a bit of innovative work in the clinic and think in some ways, but one of the most meaningful and more impactful work that is happening in the clinic is really around the centering of traditional medicine and healing practices, cultural practices within the clinic environment, and the work we're doing around integrating that into our clinic milieu, all in service of trying to enhance health and well-being for our relatives. Wanted to, I don't know how to go. Can you guys can see the slides on the side, can't you? I'm trying to figure out how to do this here. Concurrent. Okay.
Dr. Stately, just letting you know we can see your presenter notes. You don't have anything written in, but just we have the presenter view.
I don't know how did I do?
If you go down to the bottom right, there's that one. Yeah, pick that one. Oh,
yeah.
Actually, the one next to it.
Okay, do that again.
Or so you can end show.
All right.
Or use slideshow.
No, I'm trying to do is there you go.
Yeah.
I'm moving this. I gotta move this little bar here. That is the
is the Zoom
bar? Yeah, it's like
it's always just right in the way.
It's really quite okay, so it's the bar.
Try the next. Try that. Yeah, the one to the left. One more over.
That one?
Yeah. The reading view.
No.
Ooh.
Well, I don't know.
What have you tried like play from current slide instead of presenter view?
Yeah, I don't know how to do, like it's just going straight to presenter view. Not really sure why it's doing that. That's a little odd. That's never actually happened to me before.
But in custom show, can you click custom show? Probably that'll work also. In view, custom show. There, you were there right now. And there's a display button, custom show, and a display button.
No, it just says about. I mean, I don't really care if you see my presenter.
I'm so sorry.
If you don't mind, I don't mind. I mean, then there might be some.
If you go down to the bottom right,
it's so odd because I just used this presentation the same exact.
Try the reading view. See the one that's in the bottom right and it's highlighted. Go 2 over. Yeah. There we
go. Wow.
Oh.
You know, reading view just doesn't seem like it would be the thing that you would actually choose. So, but okay. Thank you for that. I appreciate that. So I'm gonna acknowledge really quickly who I am and where I come from. You know, I'm a Indigenous man, and I have this really important title that people seem to think is really important, and I think the work I do is important. But I think the most meaningful and important work I'm doing right now is raising my twin sons who are 17 years old, my twin boys, who are Dakota, and a little bit of who I am is kind of, the work that I do in the clinic is really informed and grounded in all of the things that I have learned as a young man growing up in an Indigenous community, being taught by Indigenous leaders and elders and folks in my early life, but also raising my sons and kind of trying to, with the intention, raise them to be Dakota boys on Dakota land, learning their language, their songs, their ceremonial practices, and those things. And I want to also acknowledge this slide down here is also intended to kind of just acknowledge that we're on Dakota land. And this is a picture from far away up at the top of 13 overlooking the Bidote. So that's the creation space and the birthplace of the Dakota people. A little bit about NACC. Here's our mission. We promote health and wellness of mind, body, and spirit in the Native American families. So we actually have a very lengthy, long mission statement, which is longer than that, but that's our core mission. We really do try very hard. We work really, really hard to sort of situate these values at the center of what we do in our work. And one of our most important values, I think, of the organization, and we've worked hard to advance that, is to be a good relative to everyone, to be a good relative to each other within our clinic, which has been challenging during the pandemic and post-pandemic, but I think we're making some real good strides in that in terms of helping to advance staff well-being and also reduce burnout and really help our staff and our providers and all of the other people who serve the community to feel a little bit more connected to their work and connected to each other in a meaningful way. And that's been really important. We are FQHC. I saw somebody's comments in the thing, and yes, we are 2 blocks from Community University Healthcare Center Coop Clinic. Also a couple of blocks north of Indian Health Board. And we're located in the Minneapolis American Indian Cultural Corridor. And those of you that are living kind of outside of Minneapolis, you are at the Twin Cities, and maybe you're living outstate or further out in other parts of the state. If you've never been to Minneapolis, the Cultural Corridor is about a 6 or 7 block stretch of Franklin Avenue, which is about 5 blocks south of the US Bank Stadium, between Chicago Avenue and Cedar Avenue in South Minneapolis. This is a list of kind of the things that we do as a community health center. Of course, we do the full range of primary care. We provide outpatient mental health services and behavioral health services, dental. In 2018, we launched this traditional healing program to sort of advance spiritual care and cultural healing practices in our clinic. Around the same time that we actually launched our intensive outpatient treatment program in partnership with Red Lake Nation. We also, about a year after that, we launched our our MAT program at the clinic to address opiate use disorder, and we have a daily dosing program that provides a range of supportive services to people struggling with opiate use disorder, the majority of them who are also homeless. We have outreach services and harm reduction services as well, and we provide a lot of other services to the population, which I'll describe a little bit. 85%, between 75 and 80% of our population in the clinic is Native American, and well, there's 11 tribes in the county or in the state. In the Twin Cities, we serve a little over 130 unique tribes in the metropolitan area. people from all as far away as Alaska and the Southwest and Eastern coastal tribes and a few other things. So we're a pretty mixed bunch of people. The preponderance of our native patients that we serve, though, are from some of the bigger tribes, and the majority of our patients are like from Red Lake, White Earth. I think their employed places probably Leech Lake and some of the Dakota tribes, which are closer to the Twin Cities. This is the 11 tribes of the state of Minnesota on your right-hand side. So you have 7 Ojibwe tribes at the top of the state here, up here, and then the 4 Dakota tribes at the bottom, just south and east and west of Minneapolis. This is a little bit of an outdated census tract, but we don't have a new and updated from 2020 census. But you can see, I don't think this has shifted a tremendous amount, which is this is a map that shows where the majority of the highest numbers of Native people are living within the Twin City metropolitan area. And you can see NACC is kind of like right here in the smack dab, right there in that really dark circle, or that really, and NACC, as you Minneapolis, South Minneapolis, I think is important for us me to state, is that it is one of the densest and largest urban Indian populations in the United States. There are other places and other cities that have large Native populations, but they're not as densely sort of co-located with everybody as they are here in Minneapolis. As an example, I lived in Los Angeles for 18 years, and they have, I think, after New York, the New York City metropolitan area, they have one of the largest populations, but they're spread out over a 4,000 square mile county. And, they just, you don't see, they're kind of dispersed. And so they don't have, like an Indian center like we have. They don't have a lot of the kinds of things, infrastructures that we have. I think one of the benefits of being sort of like in this space and places that we do have a high number of users of these services, and so that then they get a lot of funding and a lot of activity. So when I took the helm about 8 years ago in late 2016, this is kind of some of the bigger things that we were up against as I was stepping into my role. We belong to the urban FQHC health network called the Fun Network. I call it the anti-fun network because it's not a lot of fun necessarily to be in those meetings, listen to and looking at the data and how poorly we're doing on a lot of the metrics. But we have a NACC in comparison to the other 10 FQHCs in the Twin Cities, and then also the 17 FQHCs across the state. We have some of the highest relative risk scores among the 10 FQHCs that are a part of FUN. We have some of the highest risk scores in depression, substance use, diabetes. I think probably heart-related diseases, those things. Some of the highest avoidable AD visits at the time we came in, and a number of other things. And the houseless condition was kind of significantly emerging at that point in time. So that's kind of the context in which I stepped into the clinic in my role. I think Native people across in Minnesota, but also across the nation, we have some of the highest health and wealth gaps across a number of things you can measure. So we have higher rates of poverty, unemployment, higher rates of institutionalization, like in illegal institutions, out of home placement, those kinds of things. Higher rates of dropout and lack of educational opportunities that create, those things that we describe as social determinants of health that make, things really intractable for our community. Here's a graph that shows sort of like the 4 or 5 year period leading up to 2017, about the time that I stepped into my role around the houselessness issue. You can see that in 6 years ago, or so, 7 years ago, we were among the highest number of people who were living houseless, and across all ethnic and racial groups. Today in 2024, that hasn't significantly changed. In fact, it's gotten worse. There's some recent data that I don't actually have on the slide deck here that shows that in Minneapolis, specifically in the county of Hennepin, Native people are about 33% more likely to be houseless at some point in time, in any one single point in time over the last year. If you're in public health, you probably have heard and know about the drug overdose issues in our community. These are things that have not significantly gotten better over the last number of years. I should have probably provided a link here, but the Sahan Journal, a researcher that I've been working with, Dr. Kumi Smith at the University of Minnesota, and I think she's in the School of Public Health. She and a few of our colleagues published an article that was, or we were part of a Sahan Journal article that talked about, we did county level, we did analyses looking at disaggregated data around opiate overdoses and deaths using a number of data sets. But we looked at the county level data, and what we were able to see was that Native people in South Minneapolis, specifically within Hennepin County, had a significantly higher rate of potential overdoses, higher rates of overdose, risk of like, I think it was somewhere around 44% more likely to have an overdose within, and then, which was, to me, when we were looking at that data and that kind of information emerged, I was both shocked, but also, not terribly shocked, because it kind of, I think it reified and reinforced the experience that we're having in South Minneapolis. One of the more challenging things for me personally in my role is, like, I come to work every day and I have to walk through the parking lot, and I'm oftentimes out in the community, and some of the folks that I come across are my actual relatives, meaning they're members of my family and my extended family. And one of the things that's really challenging for me on any level is it's fairly common for me to at least a couple of times a week come across my niece who is struggling with opioid use disorder and living houseless, and she's in our parking lot sometimes, which is very, very challenging. So I think one of the things that this is the non-fatal opioid overdose surveillance dashboard. I haven't updated this. I could have gone back and looked at the more recent data, but as of February of 23, a little over a year ago, one of the things that's demonstrable in this specific graph is it shows like some of the highest rates that are much higher than the overall national average are these dark brown plots, these counties in Minnesota. And what's interesting is, like, the counties that are some of the most highest ones are, of course, Monoman County, which is where White Earth is. Leech Lake and Red Lake are not too far behind. And then right here is Minneapolis, Hennepin County. Gives you a little sense of like what we're up against. And of course, with the sort of over the last 5 years, one of the things we've seen is that HIV cases and hepatitis C cases have significantly been rising in our community. And when I first got to NACC in late 2016, early 2017, my first year of being NACC's executive officer, I remember having a conversation with my medical officer, Dr. Robbie, and she was telling me, like, it wasn't too uncommon for us on a fairly regular basis, 2 or 3 times a month to have a positive hepatitis C case come through the clinic. That continued to get worse over time. And I think one of the things that you're likely to know if you read the alerts that are sent out from about HIV and hepatitis C and and then STIs from MDH is those numbers for our community continue to grow. I mean, the outbreaks in Hennepin County, Ramsey County, and St. Louis County, which is I think where Duluth is, have been steady, if not growing, over the last number of years. As a result of that, one of the things that NACC did is in 2019, or no, 2018. So 2018 was the Wall of Forgotten Natives, that big houseless outbreak. I'll talk about that in a little bit. One of the things we did, and when we started to see this rise in HIV and hepatitis C cases and other infectious diseases, we reached out to MATEC, Midwest AIDS Education and Training and Education Center, and we talked to them about working collaboratively on developing the capacity to be able to not just do testing and screening and testing in our outreach programs and also within our clinic for HIV, but also to begin to develop the capacity to treat HIV and hepatitis C. Because one of the things we had seen between the time I started and probably 2 years in, we were seeing a number of cases, and then people weren't going to like big hospital systems like the university or to Hennepin Health and the places we were referring them for care and for follow-up with HIV and hepatitis C. And a lot of that had to do with like the stigma that they would report to us about experiencing either having a history of HIV, a history of drug use, or being homeless, just the reluctance to go into those big systems for support and services. So we decided to build our own infectious disease clinic where people could access that care right inside of a community health center where they had trusting relationships with the providers. And we were lucky. We looked out MATEC and we had applied for a HRSA practice transformation grant that allowed us to be able to work really strategically with MATEC to build the capacity to be able to provide those services within our clinic. And we just finished that 5-year grant this year, I want to say. Yeah, late 2023 or early 2024. I think we got a no-cost extension that's taking us a little bit into 2024. So today we have a fairly robust HIV outreach team that goes out with the rest of the outreach team and day encampments and all on the corridor to, encourage people to get tested for HIV. We test people for, HIV, hepatitis C, and then we have a disease investigator that we don't call that person that, we call them something else. That's what the state calls them. Goes along with the team and links those people immediately to services if they have a positive rapid HIV test, which has been really helpful for us being able to get more people into care and engage them and keep them there. I think this is easily one of the most defining events in my early start at NACC was the Wall of Forgotten Natives. Is the largest homeless houseless encampment for native in that Minnesota has ever seen in its history. And at that time, the preponderance of the people that living in that encampment were Native American. At its largest, there were about 400 to 500 people living in that encampment along what is best described as a sort of like a 1 block strip of land that sort of like was bordered along Franklin Avenue to the south, Hiawatha Avenue to the east. And you can see that up here in this corner, up here in this particular aerial view of the encampment. When I learned about the encampment in June of 2018, one of my street outreach staff, Jack Martin, who is now the executive officer of Southside Harm Reduction Services. At that time, Jack Martin and John Loftus worked for NACC, and they would go out in the evening after the clinic was closed, and they would go out into the streets and into the encampments and do all their harm reduction work as volunteers. NACC kind of helped support the establishment of the organization early in its infancy. I think our medical officer is still on the board. She was one of the founding board members, but we also helped them to secure grants so that they could expand with the pace of the epidemic. And that was really important and meaningful for the work that the foundation that we're going to lay, that we have now today. Today, Southside Harm Reduction Services is one of the largest, if not the largest, syringe services programs in the state. And a couple of years ago, NACC has been working with them strategically on developing the capacity to launch a community hub to address houselessness and opioid use disorder and other drug use rather. So we're hoping that opens this year. But one of the things that NACC did in the response to the Wall of Forgotten Natives was we we were challenged by being sort of like, it was really difficult to sort of figure out how to get health services in the encampment, because we were told by our project officer and by some of the other leadership around community health that we were limited to what we were able to do outside of the walls of our clinic in an encampment, that we couldn't go in and provide like medical intervention. We could do things like go and do wound checks and those kinds of things and encourage people to come into the clinic. So one of the biggest challenges for us in that specific area was trying to figure out, I took a tour of the clinic, of the encampment rather, and one of the things that was really evident right from the very beginning was just this scale of potential public health related issues that were just fairly obvious or emergent. We had people at great risk for overdosing within those spaces, and like hardly any access to the prevention of those things. They had no bathrooms, no running water. People were defecating outside their tents and all those other kinds of things. And when I became aware of the encampment in late July, early August, I called the mayor and I asked him if he knew that the encampment was there, and he said he had heard about it, and I encouraged him to do something and said, this is like a hotbed of infectious disease happening in a fairly small part of your city, but a profound number of people, 500 people living there, was pretty dramatic. And our biggest challenge as a FQHC was to figure out how to begin to be able to provide some meaningful health services there. So we had to think strategically about how to do that. And our solution really came through a partnership with the Red Lake Nation, and also private healthcare organization that was able to help us to deliver street medicine within the encampment. So they were going through within like a couple of weeks, we were able to get a team of people going through the encampment, doing things like, checking wounds, providing vaccines for hepatitis A and other things, making sure that we were, distributing Narcan, and then we worked with all the community organizations to sort of lift a big response to that encampment. I think one of the unique things about this specific situation was between July or late July, early August, so about this time right now, 6 years ago, we had a very short period of time, about 5 months, to get people housed before winter. And through a fairly robust collaborative relationship between several community organizations in South Minneapolis, most of them Metropolitan Urban Area Director, MUD agencies, like agencies that serve Native people that were led by Native leaders, the city, the county, the state, and a lot of philanthropic sort of supporters. We were able to house about 400 of those 500 people living there, and about another 100 and so kind of went into this temporary shelter, this temporary encampment shelter system called the Navigation Center. 4 sprung structures that were just across the highway, and people were housed and through the winter there, and provided all the resources that they needed to address their healthcare and their housing needs. And during that time, we housed some people, but there was a certain number of people that just were resistant to going into supportive housing at all. And what NACC did was, at the same time we were doing this work, we were building out our traditional healing program. And so one of the things we brought to that space was the work we had started to do around traditional and cultural healing. And it seemed to be the thing that a lot of people really wanted. So then we emerged from that, and then just about a year later, we're really dealing with the emergence of the pandemic. And one of the things that was, of course, a significant challenge was, while we had successfully dealt with a wall of forgotten natives fairly decently during that 9-month stretch of work, what we found in the late fall of 2019 and going into that winter when COVID was kind of breaking out, we found that, well, there were no large encampments. Well, actually, there was a really large encampment at Potterhorn Park. But over the next couple of years, those houselessness would continue to grow. And instead of having large encampments, what we had was smaller encampments scattered throughout the city, which was actually, quite honestly, more demonstrable and more challenging to meet. But at the beginning of the pandemic, there was a lot of anxiety, like how are we going to serve some of the most vulnerable people, our elders who are sheltered in place. They couldn't get out of their homes to come and get services within the clinic and our vaccines and those kinds of things, or get tested. How are we going to serve the people living in, sheltering in place in the Little Earth? Over 1,800 people living in 212 units. That became a real challenge. When we finally got the vaccines in late 2020, and we were about to roll those out, we, with intention, we have an elders advisory group that's made up of American Indian elders, and we asked them to give us some guidance on, like, how do you think we should do this work? And one of the things one of the elders said was, this vaccine, people are going to be really mistrustful of it because of our history of being exploitative healthcare practices, all of the experimenting that was done on us with medical interventions and, the smallpox thing. And so one of the things they said to us is, like, what we need to do is we need to pray over this medicine and ask it to be a source of healing and not harm to our community. And so we brought everybody together, all of our elders, and we brought a few community leaders, including Clyde Belcourt, and we had a public event where we showed the vaccines that we were going to distribute, but we had a ceremony where we prayed with it first. And that was a really important I think, way of literally and figuratively sort of like using our culture and our traditional practices to further gain trust with our community and help them to understand the work we were doing. We also did a whole big, we worked with MDH and a bunch of community partners to create a whole social media and media campaign around getting tested and getting vaccinated. And like a lot of tribal communities and other organizations serving tribal people, NACC was, holding public events, large pop-up events to get people tested and vaccinated. And that was work that was really important at that time and really challenging. It really strained the organization's resources, but it was really important work to do because the COVID-19 pandemic was, we were, you look back historically at data, and we were one of the groups that was the most likely to get COVID. Much more likely among other racial ethnic groups to end up with severe cases and to be hospitalized, and we were dying at higher rates per capita than any other group. So it was really meaningful and important work to do. And then, of course, shortly after vaccines roll out, May of 2020, we have this event happening. And this, the murder of George Floyd and the impact on our community, the impact on our clinic was, of course, tremendous. I think the impact on the entire state, if not the nation, was tremendous. And it really did, further clarify the nature of the work that we had before us for the next several months, if not next several years leading up even to now. Really brought home right on our front doorstep. NACC is only I think 16 blocks from where George Floyd was murdered. And so it was basically in our backyard. And of course, all of the riots that happened, the uprising that happened in response to his murder had a tremendous impact on our operations, had a tremendous impact on, our work with houseless and homeless people, and also people struggling with opiate use disorder. There was a good 2 or 3 weeks or so, maybe even 4 weeks, so about a month, where it was practically impossible for our MAT patients to get access to buprenorphine for without tremendous amount of work, and advocating for them. Many of the pharmacies within South Minneapolis burned down during those riots. So getting access to opiate use disorder drugs and supports like Narcan and a few other things were really challenging. If you look at the data from that period of time, the number of opioid overdose deaths significantly rose. This number of people struggling with opioids grew significantly during that period of time, because I think that was the impact of the long-term impact of some of the results of that event that happened in our community. So one of the things that we have worked very hard on over the last couple of years in responding to all of these things that have been happening in our community, we have this, what I call this syndemic that's happening within our community. So like, well, how do you begin to respond to a community that has had significant historical trauma, but is also now the hotbed of a huge intersection of so many public health crises. Like, what do you do about that? Well, we have all kinds of public health models that help us to understand these things, and all of these things are being addressed in multiple ways. But research moves slowly. Sometimes those research programs or those interventions aren't really designed for our communities. It takes a long time for some things to sort of happen at the structural level to begin to sort of address these bigger issues. And so, of course, we're boots on the ground. So what do we have to do? We have to rethink a different a way of thinking about public health that is a little bit more centered around systems thinking. That's kind of more I guess responsive to the issues at hand. We spend, we're building the plane while we're flying it. That's kind of one of the things that NACC talks a little bit about. We've been saying this for a while. It's like, we don't have the time to sort of test everything and see what works. We just have to sort of kind of do the thing and evaluate as we're doing it and kind of adjust in real time as we're doing some of the things. And that's kind of like and we also have worked really hard to challenge old ways of thinking about like how to do public health and healthcare work within the context of some of these things that are going on. This is a slide I created for this conversation that I had at this big conference where I talked a little bit about like, this diagram, I think for me really kind of distills the scale of the work that we were up against over the last 2 or 3 weeks here in South Minneapolis. We have these big, huge things that are happening in our clinic. These issues are very, very big and at times feeling overwhelming. And these things are the things we're paying attention to, and these are getting a lot of attention. But what's happening in the background, the background here is that these things are these inequities that are happening to our communities and other Black BIPOC communities actually are, quite frankly, supported by and moved by, deep poverty and structural racism that is embedded within health systems and education systems and justice systems and these kinds of things. So as we do this work, we begin to understand, all of the things that are problematic around policies and processes and things that do not support people's health and well-being. And one of the biggest missing pieces in this whole conversation, I think, is really, quite frankly, the lack of an understanding of like who we are as Indigenous people in a very fundamental way. So I began to sort of like think about, during this process, I started realizing like I have done some work already in this area. When I was at UW, I was part of a very large multi-city urban study, 7 cities, Minneapolis being one of them, New York, Seattle, Los Angeles, Denver, Oklahoma City. I'm probably leaving one out, I can't remember. But we did a study looking at predictors of health and well-being for Indigenous, gay, lesbian, two-spirit individuals. This is one of the largest studies that has been done in that with that particular population. But we looked at people's experiences of microaggressions and sort of different experiences of discriminatory experiences, and also assess their the impact of historical trauma on them. So how often do they think of historical losses? We also talked and asked them a whole lot of information, like, did they go to boarding school? Were their parents in boarding school? Those kinds of things. And we asked them about a bunch of cultural, how often they participate in culture. Did they go to ceremony? How often were they sort of connected to themselves and their culture through relationships that they had with other relatives within the community and maybe back home on reservations. And then we looked at how well this model predicted either the ability to sort of resist the stress, the toxic impact of stressful life events like historical harm and losses and microaggressions on health outcomes, positive health outcomes, and and the model was successfully demonstrated in a number of analyses to show that culture was both a modifier of toxic stress, but also had predictive value in preventing toxic stress from emerging in people's lives. So, I remembered this work that I had done at, years before I came here, and I was like, oh, let's really beef up our traditional and cultural healing practices here. And so during this time, we had also started the traditional healing project, but over the last 3 or 4 years, we have grown this department and this division within our organization significantly. One of the most fundamental things that really changed this trajectory for the clinic was this, I call him like I lovingly called Frank. His name was Frank Two Bears. He was a homeless man who had been one of NACC's longest clients back in 2018 at the time that we started this project. He came into our clinic on a day that we were doing a blessing for the clinic. Donna LaChapelle, our first traditional healer, she and 4 of the young women she was mentoring in her traditional healing practices, kind of went through the clinic, smudged all the areas. They sang songs and provided prayers for our clinic and also the community. And we were hanging out in the lobby, kind of finishing up the ceremony, and Frank walked in the front door, and he saw that we were holding a bowl of smudge, and he walked up to us and asked if he could have some medicine. Don held the bowl of smudge out to him, and when he smudged himself. He bent over and smudged himself, and when he stood up, he had these big, huge tears in his eyes, and he said, "I haven't had any medicine for 7 years." And he was crying, and he kept saying, "Thank you, thank you, thank you." And he started to leave the clinic, and the women ran out and gave him some medicines to take with him. And we bundled up some cedar, sweetgrass, and sage, and some tobacco for him, and sent him on his way. That was actually one of the last times I saw him. But when he said those words, "I haven't had medicine for 7 years," it had such a profound impact on me that I made the decision at that moment in time that our first foray into sort of growing our traditional healing program was that we were going to create a medicine garden, and make sure that people like Frank, who were houseless, other people in our communities who don't have any ability to get outside of the Twin Cities, they don't have any access to traditional medicines. They can't maybe afford to buy it. A lot of people can buy sage and sweetgrass and those kinds of things, but they don't have the ability to buy it, and they don't have the ability to go back to their home reservations and get those things. They can't go home for ceremonies. We decided that we were going to do that, and so we kind of all got together, and we made a prayer, based on Frank's request, and we started this little medicine garden project that's out in front of our clinic now. And here's the progression of that medicine garden over the next 2 or 3 years following that, the initiation of that prayer. We planted sage in the wolf garden structure outside of our clinic. We put the Dakota and Ojibwe floral designs on there that represents our medicines that we use in our healing practices. Floral designs are one of the ways we, through oral tradition and other ways of transmitting information, we teach people about our medicines, our elders, and our children and our youth. Our first year that we had our medicine garden project, and when we were ready to have a harvest, we invited all of the people in the community to come back and help us harvest, and we taught them about the medicines if they didn't know about it. We created note cards about what each medicine was and how to use it in various forms. And then the next year we partnered with the University of Minnesota to make the medicine garden even bigger than just the planter. So we created more medicine, more access and more medicines beyond just the 4 traditional ones. And the University of Minnesota helped us build that project out even more. And we had community coming in, helping us. We had staff from the university creating that medicine garden for us. And today, this is a little bit what when it was finally finished, we had the fully decorated garden here. You can see back here on to my right, off in the distance, This was work we were doing even during the George Floyd murder events. This work, traditional healing, has been guided by Elders Advisory Council that we established shortly after deciding to do this work, and they continue to guide all of the work that we're doing in and around cultural and traditional healing practices, even as we do the integration of this work into our clinic MAU. They guide this process and they help inform how we do this. But between the beginning of the pandemic and now, we have grown the traditional healing program from 2 providers to 5, and we now have grown the departments. This is an example of some of the work we did over the last 5 years or 4 years during the kinds of things we did. We did medicine walks, we did plant walks, we provided elixirs, and we helped people make regalia so they could participate in ceremony. A lot of our people in our community will be like, I want to go to SWAT, I want to go to these ceremonies, but I don't have moccasins, I don't have the regalia or the ribbon skirts that I need to wear, and those kinds of things to participate in ceremonial practices. So we provided all those things for them so that they can feel comfortable stepping into that space. And we provided them with not just the resources to do that, but we also taught them. If they lacked the knowledge, we provided the knowledge for them by bringing in speakers and elders and healers. And today, it's one of the biggest divisions in our department. It's as big as it's bigger than our behavioral health department, actually. Today, we provide 2 ceremonies a month in the community. It was really important in this work for us not to make it a requirement that people be a patient of NACC to access this medicine. Was my, from the guidance from my elders that I heard loud and clear, and it was even evident with Frank, kind of this idea of like, these are things that should be available to all of our people all of the time. They shouldn't have to be a patient of NACC and come in for it with a visit or come to see a doctor to be able to have access to this. So we worked really hard to make these things available to the entire clinic. About a year ago, we started working with our young men, because what we were hearing from young men is that there was a preponderance of interventions and programs that were supporting Native women, women with children around opiate use disorder and recovery. And these men felt lost when they came out of jails and other institutions. They kind of had a sense of not really understanding who they were and where they belonged. So we launched this men's project so that we could just bring them together. And we started with the creation of a drum group. And that drum group grew into this big, huge young men's work. So twice a year in the summer and this winter, we have these 3-day camps where they go and they learn about traditional practices. They work on building relationships, and they do all these other really amazing things. So we just had our 2nd annual summer encampment about our camp, men's camp, about a month ago. We also built out over the last couple of years a strong maternal and child health program to give our kids and our young ones in our community the strongest possible start they can have. And that work is also embedded deeply in traditional practices, everything from, indigenous medicine, our milk medicine, making sure that milk banks are available, breastfeeding workshops, cradle board making workshops, a number of other things. And of course, we put the medicine and the traditional practices at the center of that work. Some of the other ways we're investing in building strong children from the ground up, from the day they're born, is we built out these programs that sort of address healthy eating and physical activity with our young people, because they have a significant likelihood of becoming diabetic and or obese at very young ages. So we created this program called Project Braid. It's a research project, it's an implementation study, actually. We pulled together a group of community partners who have been working in indigenous food and medicines and gardening and those kinds of things, like Dream of Wild Health and the Indigenous Food Network and a few other people. And we also brought in partners from Indigenous Twin Cities Native Lacrosse and other partners to encourage young people to take up the some of our indigenous games and our indigenous foods as a normal part of their daily lives. And this is a project that's in its third year, and one of the greatest successes we just had is we're working with the Indian Center and their Boys and Girls Club, and they're going to adopt this program that we developed as their after-school programming for all of their youth for this next year, which is really exciting. And then the last thing I wanted to say is that 2 years ago we formed a partnership with 5 other organizations, 3 of them Native American, 2 of them African American, and we created the Birthing Justice Collaborative. And this was to address the poor maternal outcomes and birth outcomes for Black and Indigenous women within Hennepin County. And we held 5 or 6 listening sessions within the community. We listened to Black and Indigenous women tell us about their birthing experiences and the things that they want and needed as part of a healing process, but also what would help them to sort of have more successful and more meaningful and healthy birthing experiences. And we created this 5-pronged strategic plan to address birth outcomes in Hennepin County and the Twin Cities. And NACC's working with the Minnesota Indian Women's Resource Center, Division of Indian Work in Minnow Clinic, which is the Red Lake Clinic at the underneath their housing project down the road. We are in the process of developing the planning. We're in the planning process of developing and launching, and in the United States' first American Indian Birthing Center. And we secured a $350,000 grant from the state legislature this last session to be able to do that work. And then we'll be developing the birthing center over the next several months with the community, the strong community voice and direction from our elders and our traditional healers and our birthing women. So that's a big part of what we're doing. Last but not least, we're building a brand new health center. So here's some designs for our new health center. We're also putting 4 floors of housing above our new health center. And that's because housing and houselessness is at the center of probably one of the biggest social determinants of health. We're trying to do our part to help relieve that from our community, do our 83 to 84 units of housing, and all of it deeply affordable, and about probably, I think, 20 units altogether that'll be supportive housing and or Section 8 housing. Inside the clinic, see some drawings of the early iterations of the clinic. We went to Chief Seattle Club in Seattle to visit them. They had built a new clinic in the basement of their new housing development, 10-story housing, 10-story affordable housing building. And one of the first things we experienced when we went to go to see the Chief Seattle Club's new building is you walk in their front door and immediately I could hear drums, and I thought they were piping in the music. Like I was looking on the ceiling for the speakers and I couldn't see anything there. And I was like, where's your music coming from? Are you playing a CD? And he was like, no. And the guy that was giving us the tour of this building was, no, look at this. And he went over to the wall. It looked like one big, huge, like the wall of wood. And he pushed on a part of the wall and it opened up into this drumming circle that was at the center of their lobby. And I was like blown away by it. We sat in that drum room and we had the rest of our conversations and talked about how they grew their work with the houseless people. And one of the things I made a decision then and there with my team was that we were going to build this at the center of our new building as a literal and figurative representation of our motto, which is we are centering our traditional healing practices at the center of what we do in our healthcare system, and we're putting all of the Western practices around that system. But unapologetically moving in the direction of centering all of our indigenous health practices, because we know that those are the things that have been missing for the last 100 years or so within healthcare, and that this is a really important step to sort of healing our community. And so we're centering that at the work we do. On this one slide over here to the right on the top, you can see an external view of that drum room and at the center of our lobby. And one of the things that you can see also outside is that medicine garden is going to be a big part of the grand plaza that's outside of the clinic. These are ways that we are demonstrating and with intention centering culture and identity and all of those practices in the health and well-being for our community and for our clinic population. So that's the future. That's where we're moving. So I realize I went a long time. I took up the majority of your time. I really apologize for that. I can't. Oh, here.
It actually ended right when we really sort of wanted you to.
Oh, okay.
I am blown away. I have some questions, but I am going to take a pause and let's, maybe spend, if you have time, let's spend the next 15 minutes,
Yeah.
do
Yeah.
questions as a group.
Happy
I
to
know that
take
there's
questions.
2 questions that came through the chat already, but major snaps, major, high fives and clapping on the
Thank
way.
you. Very sweet.
Very, mind blown. So I'll take my pause, but major snaps. Yeah.
Thank you. Mhm. Any questions? Oh, yeah, no, thank you for putting the article in there about the voice for it. So we have talked about, NACC has talked about trying to figure out if there's a way for us to put vending machines in our lobby or in one of the things we did was we got a recent grant from MGH. I think they funded 6 organizations in South Minneapolis to put in to help with the needle exchange programs to do a better job of getting dirty needles off the street. And so we did that. We have these big huge, they look like big huge red mailboxes. We have one outside of our back door. We're working with a community partner to identify which community partner might want the other one. We also are putting these, we got some funding to make Narcan more accessible to the community generally. So we're going to put these Narcan units in high traffic areas so people have access to Narcan all of the time. I think one of the biggest challenges we've seen over the last several months is that it takes people multiple doses of Narcan to revive people, right?
And do
Because
you provide the train? Do you remind me the
we
training?
do, yeah. So our
You,
community,
okay.
yeah, our community outreach team and harm reduction team goes out and trains our community partners on Narcan and Narcan distribution and how to use it. We train them on a number of other things as well, but that's a big part of our work. We do that and with partnership. We do a lot of that in partnership with other organizations like South-Centered Harm Reduction Services and a few other things. One of the things I failed to tell you about, I forgot to tell you about, is you might have heard, I know that they have a website. I'm not a website, they have a Facebook page and I think maybe also an Instagram page. It's called Project Build. I don't know if you've heard about this. Kumi Smith and some of her colleagues, they created a monthly meeting to begin to sort of track and better understand the encampment issues in and around Hennepin County and the Twin Cities. And so they meet every month to talk about, listen to people who are houseless about, their experiences around encampments and encampment sweeps. They're tracking the encampment sweeps and the impact that it has on public health outcomes like infectious disease and opiate use disorders and those kinds of things. And you can find them on Facebook and join, and that will be one way that you can kind of learn a little bit more about that work happening. NACC is connected to that work, but that work is being led by a group of people in the community.
Yeah, well, we might follow up with some, direct links to some of the resources that you've, been referring to throughout the presentation. Including Project Belleville. We can add that to the list as a post follow-up meeting summary. We'll include some of this information as well. One of the first questions that we received in the chat was from Lori, who said, do you provide outreach services to elders? This is one of the first questions, and it sounds like, obviously you all do, but
to others or
to others. Yeah.
Elders?
Services to elders.
Yeah. One of the things that we've been doing is, so there's a elder housing that's about 3 blocks to the south of us on 24th and Bloomington. And one of the things that we started to do last year was I have this grant writer, Sarah Anderson, who's like, she kind of like, she wanted to do the men's work. So I said, like, I gave her the green light to do it. We didn't have any money. I was like, well, let's go ahead and do this work, but we have to find money. So she's like, it's okay. I'll write some grants. And she did, and she got them. And that's how that started. But she also decided, like, one of the things that she thought was really important was to sort of kind of give those men a sense of purpose. So she kind of connected those men to the elders, and those men go over there and they rebuilt their lot there. They fixed the fence that was broken on their building. They did some repairs to their lawn, to their gardens. They planted medicines over there. We've been doing more of that kind of work where we're helping elders to, and we actually used to have an elders advisory council that was made up and comprised of mostly like people who were old, but were also sort of like academics and a few other things. And across the Twin Cities, we decided to sort of like, go real tradition. We asked a lot of these elders that were living in and around our community to be on that board. So they were that elders advisory committee is made up of people who are actually elder people living in our community. So they kind of bring along not just their knowledge, they also talk a lot about what it's like to be an elder living in housing or living, kind of disconnected from the community. We're trying to build as much internal support to be able to support them. We host, this is our second year hosting interns from both Indigenous Peoples Task Force and also MIGAZ, young people who come to our clinic and spend about 6 to 8 weeks with us in the summertime. Those young people we've been connecting those young people to the elders. So they go over there and they do things like help them clean their apartments, make medicines for them, those kinds of things. They do a lot of really cool things. So it's a big part of like the work we've been doing. She wants to expand some of that elder work. So we got some grants that we're developing right now to get the elders out of their homes and out of South Minneapolis and get them into like, green space and able to be out in spaces and where they can, do foraging and plant medicine walks and those kinds of things and other kinds of activities that will increase their physical activity, but also their mental well-being and a few other things. So yeah, we're doing some of that work as well.
The power of connection and green space and purpose. All
Yeah.
three you're hitting on the spot. I see that, Lori, you're on camera. Would you like to? I don't want to speak for you, so feel free to, if you have a follow up to your one point. Or oh, you want me to go? Well, it's just okay, well, sounds like it looks like we're having a muting issue, but in the chat, Lori says we have a grassroots health clinic with volunteer health providers at Elders Lodge in St. Paul. We would like to integrate healing practices at Elders Lodge.
We have done some work at the Elders Lodge. It's not been easy for us to get over there and do it because some of our volunteers don't have cars. We rely on a lot of people to do some of that. But I know that Sarah has done some stuff at the Elders Lodge. She's our grant writer. I think if I'm not mistaken, I think she told me that they asked her to be on their board. So she'll be very engaged here soon. So yeah.
And Andrea, I see that you're also on camera too, and you've asked at least 2 questions. Do you want to come off mute and share them? I don't want to speak for you, Miss.
Oh, yeah, I'm just curious about where the new clinic with housing, it looks like it'll be pretty sizable. And their plans for the courtyard, the plaza. So I'm just curious as to how close you'll be able to put that to where the current clinic is, knowing there's not a lot of space there, but maybe you have creative options.
We're putting it right at the front of the clinic, so we're gonna build it in our parking lot. So once we break ground in March of 2025, we'll have to be really creative in the way that we sort of operate, because we have to operate for the 16 months or so that we're going to be building the building. And we have a whole plan on how we're going to do that. And we don't expect it to have access is going to be an issue for sure. It's going to be an access for the staff as well, access issue for the staff. The preponderance of people that park in the parking lot, mostly our staff, they're not our patients. A lot of our patients take the bus, they get rides from our van service, they get dropped off, or they walk, or they, some other sort of form of transportation or ability to get to here. So we expect that that's going to be a little bit of a challenge, but it's probably going to be more of a challenge for our staff for sure. So it'll impact operations a little bit. One of the things we plan to do is we're going to change the entrance into the clinic here in the late fall. We're going to start the process of demolishing one side of our existing building where most of our administration is, so that we can create patient parking, prioritize patient parking there. Staff are going to be incentivized to, carpool, ride the bus, take an Uber, ride their bike, walk, those kinds of things. We'll be spending a lot of money giving people financial incentives to find other ways to get to work. And then we're going to reposition the entry of the clinic into the back of the clinic, right off of 21st Street. So we're going to be doing some internal sort of work over the next few months here, starting I think in October or November, to begin that process. It's a good time for us to do it because during the winter our encounters kind of come down anyway, and people are less likely to kind of be out and about in the winter time, especially during the time between Thanksgiving and New Year's. So yeah. It's
Great.
exciting, but not challenging, but also exciting work. So
Very exciting. Andrew, do you have
we're gonna
questions?
learn from the pandemic. During the pandemic, we've learned we can do a lot of stuff virtually. So that's kind of what we're gonna lean back into while we do the building of the building. We'll do as much of our visits virtually as we can. A lot of our behavioral health work will probably happen through virtual telemedicine. So anyway.
Planning.
Yeah, planning. We've been planning for years, actually. But we're 3 years into the planning process here.
And you must have, maybe your grant writer, Sarah, wrote grants for the rest of the funding. I'm sure the $350,000 from the legislature doesn't cover a lot of the costs. Or
No,
maybe
the
did.
$350,000 that we got from the legislature is specifically for the birthing center, which is another project. The birthing center won't be in the clinic. It's going to be in the community somewhere because it's a investment of time and energy and resources from 4 organizations. But the new building is a $53 million project, and the clinic portion of that is about 25 million or 22 million, something like that, 23 million. I think 23.7 million. And we're still raising the funding for it. So you, your family, anybody you know, is interested in supporting it, there's a donation page on our website. But also, you know, we're close to closing the campaign. You know, we have about 3 or 4 months to close the funding for it. So, but we're very close. So.
The final countdown. Who's gonna be the last one, you know? Race to the.
Well, yeah, I mean, some of it, it's so challenging because some of it is based on, you know, I kind of feel like the final amount of like the final number of like what it's going to cost us to build keeps fluctuating. It's like, you know, based on what the cost goes up on some things, but comes down in other areas. And, you know, I mean, today it costs more to build than, you know, the budget we had in 2021 is not the budget we have today. It's like, you know, it's like 35% higher. So
It's like the
yeah.
green line or
It's like,
Yeah.
yeah.
the. Does anyone else please come up to me, raise your hand? Any questions? Any more questions? For our presenter here?
I have to go because I have to pick up my kids here from hockey in
Okay.
20 minutes. And I think I would say anybody, I mean, the last slide, I don't know, I can show the last slide. Or you all know how to contact me. I think you have my email address. Happy to have you share my email address and contact information with your membership. And if anybody has questions, wants to take a tour, wants to talk to me more about the work, you can just reach out to me by email, and I'm happy to do what I can to support that. So
Fantastic. I know I will. So have a good evening. Thank you so much.
thank you so much. I appreciate the time and the opportunity. Have a good evening. Bye.
Have a good evening.